It's an interdisciplinary organization originally stimulated by case managers. So these are the folks who are dealing with transitions on a daily basis, and I think they've done a nice job. A number of pharmacy organizations are part of the coalition. They range from managed care to ASHP with the health system pharmacists, and also long-term care pharmacy. So there is significant pharmacy representation on INTOC. And then the last thing, ACCP, my home organization, produced a white paper in 2012 on transitions of care. And I sat on that committee, and it's also worth a read. It gives some history and background, but it also gives some recommendations on what pharmacists can do to improve the setting. So with that, I will move on to our speakers here. On my right, first is Kathy Getz. Kathy has 29-year pharmacy experience in areas including patient safety, hospital staffing, long-term care consultant, home health care, infusion services, and retail pharmacy, so a very broad background. In 1992, she joined St. Luke's Hospital, where she is currently working as the hospital's pharmacist discharge medication reconciliation project. Kathy is a graduate of St. Louis College of Pharmacy and served on the board of trustees for St. Louis College of Pharmacy since 2011, and as a pharmacy consultant for the Missouri Board of Pharmacy since 2009. Next is Dr. Doug Pogue. He is medical director of the BJC Accountable Care Organization here in St. Louis. It's a 500-plus physician entity that manages more than 62,000 Medicare beneficiaries for the St. Louis and surrounding areas in Missouri. He also is Associate Chief of Medicine at Missouri Baptist Medical Center and serves as the chairman of the advisory board for the BJC Medical Group. Doug earned his medical degree from Washington University and completed a residency at the University of Maryland. He is board certified in internal medicine and has served as the team physician for the St. Louis Rams from 2000 to 2012. His professional focus centers on geriatric care, sports medicine, and health services delivery strategies. So thanks for being with us, Doug. Next is Anastasia Armbruster. Dr. Armbruster is assistant professor of pharmacy practice at St. Louis College of Pharmacy. She also is clinical pharmacist specializing in cardiology and internal medicine at Missouri Baptist Medical Center. She graduated from St. Louis College of Pharmacy in 2009 and completed a PGY1 residency at West Virginia University Hospital and a PGY2 internal medicine residency at John Cochrane VA here in St. Louis. And last on the end, but certainly not least, is Dr. Clark Kebido. He's an assistant professor of pharmacy practice at St. Louis College of Pharmacy and a shared faculty with the Walgreens Pharmacy. In this role at Walgreens Wellness Center, a pharmacist-based clinic, he's responsible for delivery of community-based pharmacy clinical services. Clark currently serves as the primary site preceptor at Walgreens for the PGY1 St. Louis College of Pharmacy Community Residency Program and primary preceptor for several APP and IPP students on rotation. He is also serving as the vice chair for a work group within the pharmacy e-health IT collaborative. So give our panelists a round of applause. And so what we'll do, you have some cards. If you think of a question that you would like to ask, feel free to jot that question down. And Stephanie, I don't know if we're going to come down and pick them up, or just if you want to shuffle them forward somehow, we'll go get a hold of them, get our attention, and we'll ask your question. Otherwise, we have some as well. So maybe I'll start off by asking the question of the panelists, and anybody can answer, and maybe all these early on questions, maybe all of you will have a perspective you'd like to share. But what types of breakdowns have you seen occur with round discharges from the hospital and transitions of care? What breakdowns with regard to, in particular, medications, but even outside of medications? What are some of the vulnerabilities in our system as it exists today?
from the inpatient perspective, so again, I'm an inpatient hospital pharmacist, I think a lot of times we depend on the patient to communicate the information to their outpatient providers. Specifically at Missouri Baptist, we're fortunate because those providers within the BJC healthcare system.
Make sure that's on.
Is that better?
Kathy and Clark, you can hit yours too. Okay.
So for those who couldn't hear me, just that I feel like a lot of times right now we're depending on the patients to communicate a lot of information as to what happened during their hospital stay. And I feel like that can be a struggle for them. While we're fortunate within the BJC healthcare system that we have a large network of hospitals and technically the physicians can access all of the information from that admission, I feel like we still count on the patients a lot to communicate that information. And when you take into account their health literacy and their ability to understand changes and why those changes were made, it definitely lends itself to a lot of errors. And I kind of think, would I want to do my taxes on the day I got discharged from the hospital? Because it's easy for us to think, well, you should understand all of this information, but when you put it in a perspective of maybe things we don't understand, you can kind of start to see how that's very difficult for the patients to manage those transitions.
Anyone else?
Yeah, I think another thing that's important to know, particularly from the pharmacy perspective, is that medical care itself inside the hospitals and outside the hospitals is actually becoming more fragmented over time. Despite 20 years of us saying, hey, the U.S. healthcare system is too fragmented, we need to pull things together, information needs to be more transparent and flow with the patient as they transition in and out, we're actually becoming more fragmented. Why? Because physicians in general are starting to choose careers either inside the hospital exclusively or outside the hospital exclusively. So particularly in primary care, which is my field, you'll see folks decide that they're going to be a hospitalist. They're going to work on the floors of a hospital and nothing else. They don't follow patients out of the hospital or transition with them at all. Other physicians who are in more of the outpatient side of things never set foot in the hospital. So I never thought of myself this way, but in the last couple of years I realized I'm a dinosaur. And why would that be? Because I'll actually see patients in the hospital. When they go in the hospital, I see them there. If they go have a surgery, I show up after surgery. So as the transitions happen, I'm not surprised when a patient shows back up at my doorstep with a unknown list of medicines that the patient doesn't understand. I don't have phone calls where people say, hey, you know, the hospital put me on this. Is that right? I don't know if I trust that. Maybe I'll just go back to my old medicines. Increasingly, a lot of medical care now is done with the outpatient physician in that transition situation saying, well, I really don't know what they did in the hospital. I guess maybe follow the same medicines. Why don't you see me here in the next couple of weeks? We'll figure it out. And we know within the first couple of days after you leave a hospital, if you don't have the medicines right, then especially in the group that I deal mostly with is seniors, those 65 and older, a lot of bad things happen to folks when they come out of the hospital and things are messed up. And so the need for collaboration in my mind has never been greater because my side of the equation is starting to become more fragmented with people becoming so narrowly focused that you don't have anybody following the patient all the way through. And so how we can then utilize our different skill sets and collaborate at the different points of transition is going to be really critical to keep these folks well and to keep things kind of running well.
Would that have something to do with the situation where doctors actually don't hold their own offices anymore? They're more or less like part of a group system?
Yeah, there's a lot
So
of...
if we could repeat that question.
So
too,
the question was, is that one of the reasons that physicians don't want their own offices anymore, that they tend to be more employed and become part of large groups? Yeah, there's several trends in that. One is that the payment structures, particularly government-based payment, Medicare, Medicaid, those kind of things, are making it very difficult to sustain an independent practice. It's just very difficult to make it on your own and have your own building and that kind of stuff. The second is generational, where you have the millennial group of young physicians that are coming out. They have no interest in doing what a lot of us did. They don't want to work the hours that we did, see the number of patients that we did, get calls in the middle of the night like we did. They just have no interest in that. And so you'll see a lot of your physician peers that are probably in their 60s or early 70s who have a building, they have a staff, they have all this, they have this big practice, they're looking for a great young physician to sell that to and pass the baton, and nobody wants it. They can't sell it. So there's some things that are changing a lot, but the biggest thing is that the new generation of young physicians has no interest in even 5-day-a-week kind of practice. They all want to be part-time, they all want to have limits, they all want to have a reduction in call and that kind of thing.
Plus, there's
Right, exactly. And so for instance, a search firm told us a year ago, if we want somebody who actually will work 5 days a week, have a primary panel, and see their patients in the hospital, there's between 1 and 5 people, not percent, but people for the state of Missouri per year that will fit that category. And you have a whole state that's competing for those few folks that will actually do that.
Kathy, you want to answer?
Sure. So simply things that can go wrong in transitions, especially out of the hospital, are common things. We have the wrong meds, the wrong doses. These break down sometimes because of the computer system. We do a lot of therapeutic substitutions in the hospital, so we have to watch when a patient goes home if they get scripts for new things and they're not doubling up on the meds. They're going back to their home med if we switch their PPI or whatever it was. And then there's compliance. Are patients filling their scripts? Why aren't they getting them filled? Sometimes it's just the complicated medical system, their insurance, their workers' comp. One is saying, yes, they should be covered under it, but then the prescription is saying, no, they're not, we're not going to cover that med. It's something expensive that possibly is critical to their care. So we have put pharmacists up on our nursing divisions to help aid and assist to make sure that those critical things don't fall through the cracks. So certainly we don't catch everything and we don't know what we don't catch, but we certainly catch a lot of things that go outside the hospital at that transition in care.
Clark, from a community pharmacy perspective, what do you see happening, on a weekly basis, folks who discharge from the hospital?
Yeah, especially as it relates to breakdown, the thing that I find most often happens is not necessarily an education piece. Oftentimes these patients have been educated multiple times throughout their stay. They're educated again when they come to community pharmacy. It's really that communication. It's, I have 2 of these meds, or I have a long list of prescriptions. What's different, what's not, and oftentimes it may fall to that pharmacist who's working there that day, and the ability for that practitioner to communicate with other parts of the healthcare team has become, in my opinion, more critical than ever as we work to solve through this transition thing. But oftentimes it breaks down to how effectively, well, Anastasia said it well, we rely on that patient to report that. Wait, what are you taking this for? It's like, well, it's something for my heart. Well, as we all know, there are about 40 different things that can go wrong with your heart. So really it's working with the patient and then being able to look back at the hospital and see what happened and see why things changed will enable practitioners in the outpatient setting from their local physician as well as their community pharmacists to more effectively be able to help them take that next step, get past day 2, day 5, and ultimately day 30.
So it's very clear that there's a problem, very clear there's an issue, and it's also high on everybody's radar. So what are the programs that are available at your institutions today that maybe weren't there 5 years ago? Anything new?
So we've done a lot of things for medication reconciliation that I've been involved with in the hospital, things that have come and gone. One of the important things I think is that you have a good structure building that whole process, that it's interdisciplinary, that people buy into it, that you have support from other professionals within your institution. And so we were fortunate enough that our physicians got frustrated at the bad discharge med list enough that they went to bat for us. So we've hired 3 pharmacists, and then more recent to go up to our nursing divisions. And just recently we've hired an ED pharmacist, which we didn't have previously. And they are going to bat for us for a few more pharmacists up on the nursing division. So I guess we're doing a good job. Basically, our pharmacists are up there with the charge of making sure patients get out of the hospital with the correct medication list. So they're reviewing the patient chart. They start when the patient gets admitted because the turnover is pretty quick. So they start taking notes. We've given them a lot of support to work together as a team with other individuals on the nursing division, and computer support where we've done a lot of build there for them to make their job a little bit easier. But their main job is look at that whole patient picture. Look at the progress notes from the physician. Look at the consult notes. Make sure what everybody was talking about was completed before the patient leaves the hospital. If it if it involved medication. So after they do all of that, if there's any updates, they call the physician, they make the changes on their discharge med list, they go in, they educate the patient, use the whole teach back method, trying to, maybe we're overdoing that, maybe we got so good at that, that we need to move on. But they're doing a great job at giving back data to me on what they're doing so that we can go back to our team that's supporting the pharmacist up on the nursing division. So that's kind of what we've done, and they've found a lot of problems along the way. We've been able to address them quickly with our interdisciplinary team. Sometimes it's one person, sometimes it's a department. Our first big problem that we really identified was that at discharge, it's very time consuming to update an admission med list that was incorrect. And the patient got the wrong med the whole time they were there, and it's identified 7 days later when we're discharging them. So their discharge med list is done. Now we gotta back up and try to figure out what really should they be on and start over with that discharge med list a lot of times. So we realized that we needed to put some efforts into getting a better discharge med list. Also, in doing the project, we knew that we weren't gonna be there 24/7. We weren't gonna get enough pharmacists to do this all day long. And so we still had to keep our old processes in place and not break those and let everybody know that we are just there for 8 hours a day, 5 days a week. And since then, we've gotten some weekend coverage too. And so there's been a lot of pieces to the project, but there's been a lot of support. So we were really fortunate. We think that the med lists that are going out are so much better. Our pharmacists are doing a phenomenal job up on the floors. I go up there and talk with them and check up to see if they need anything, what they need while they're up there. And they're just very detailed at putting intervention notes in, making changes, finding things that are incredible wrong at discharge. So I think that as a group, we have a lot of opportunities, and people know that we are the drug experts to make things correct at these transition points. And I think the better job we do with each little piece, the more we're going to be trusted to kind of move on and do more.
Yeah, we've really had a similar experience. It's garbage in, garbage out. So you have to get things right coming into the hospital, or it will be wrong, during the hospitalization and wrong coming out of the hospital. But at the time that someone's in the emergency room in a crisis situation and they're 85 years old, it's challenging to get all the correct, the correct names, the correct dosages, everything right. And we've kind of gone on the same type of odyssey over the last couple of years. Initially trying to say, okay, well, let's connect our outpatient record with our inpatient record, so we can actually look into the outpatient record to see what they're on. Well, as all of you know, that's just what the doctor thinks they're on. That's not what they're actually filling, right? And it's not what they're actually taking. And then we have to marry that with, okay, well, let's talk with the patient, let's talk with the kids. And in this age group, often you'll have family there. And let's bring in the bags if we can. Let's invest time. And as we've kind of done that through a process, you slowly get closer to an accurate list. But still, and I think our experience has been true nationwide, it's still frighteningly inaccurate. And so the next step that we're doing is actually, I think, what you guys have already instituted, which is say, okay, we need to get pharmacists more involved. We just have to. We have to have folks who really know what they're doing. Spend time to investigate this, correct things, make sure it's right, make sure it's understandable, the language that the patient and the family get, and have those processes in place so that when they're in the hospital, it's right, and when they leave the hospital, it's right. And if there's an issue or a barrier, like for instance, this medicine is going to cost you $300 a month, are you prepared to pay for that, or can you afford that? We need to know that before they leave the hospital, and then show up 2 weeks later in the doctor's office and say, I never took that antibiotic because it's really expensive. So we need to do that on the front end, and so that's collaboration. We're there as well.
So I think Dr. Pogue alluded to a lot of things we're doing at Missouri Baptist. Specifically, right now we have pharmacists. So we started with a pharmacist in the emergency department. Pharmacy is now taking responsibility of the admission medication reconciliation. Our director of pharmacy is here. I'm sure he would love more pharmacists to do the discharge med recs as well. But right now we just physically don't have the bodies to do the med rec at discharge. So that's one big transition. We also purchased a program that we can look at third-party payment information for filling history, which kind of can help fill in those gaps that patients often have regarding doses and the details about their prescriptions. However, there are still some insurances that don't subscribe to that, so obviously that's a limitation, but can be helpful. The other big thing I can think of at Missouri Baptist is the hospital took the initiative to start a congestive heart failure clinic. And so getting really at, obviously heart failure is something that Medicare pays a lot of attention to when it comes to readmissions. And so really dedicating some staff to those patients and help prevent them from coming back to the hospital, specifically within those first 30 days. And that is a nurse practitioner run clinic at this time.
So like many community pharmacies, ours does transitions of care based on proximity to a hospital, right? Experience and what the pharmacist does. We see that script and we work with the patient, but it's not necessarily a formal program. The one thing that I wanted to speak about specifically was certain Walgreens throughout the country have done something called a Well Transitions program, and I don't think it's necessarily unique to one place we have, nor do I really want to talk about it that way, but there's two main components that I think are critical for it to be successful and give patients the ability to really reduce readmissions, increase adherence. One is a system that talks to the hospital, giving the pharmacist the tool to see the discharge note. This prescription alone simply isn't enough for a patient who just got out of the hospital, and a pharmacist trying to sync that with an old med list is enough without that critical piece of communication. The other critical component to it is medication synchronization. So when they get discharged, it's very possible that they may have 14 tablets of one medication, 20 of another, and then all of a sudden you have this huge basket when what may have started as 4 or 5 medications going into the hospital now comes out as 12 or 13. It's important to make sure that pharmacies are able to dispose of those medications, but that may be a talk for another meeting of minds. But specifically know which meds they're taking, when they're taking them, at an appropriate health literacy level, as mentioned earlier, that patient can understand. So I think those are the two critical components that allow community pharmacists to be more successful when transitioning patients out of the hospital.
And I'll go out on a limb with my next question a little bit, but there's a real emphasis on patient-centered care now and also participatory care. So in involving patients in developing the interventions and the changes that are going on. Have any of you had any experience on the panel that you've gotten a focus group or you've gotten some other way of getting patients to contribute to the processes and the workflow in your hospitals?
I think what we're doing to try to engage folks is to increasingly, I guess I'll focus this in the hospital and in the transition, is right from the get-go when someone's brought into the hospital now, they receive a folder that all of their results go into. So if they've had a test, if they've had other things, their medications, all of those things are in this folder, and that follows them through their hospitalization to take it home with them. The doc's supposed to sign off on some things there. And that's an attempt to have some kind of written record that goes with the patient. Because again, some folks will remember everything you tell them, others really won't. So you need something written down. So it's a low-tech way of doing it, but we're trying to find ways to do that. The other thing we've done, which is tries to have access in transition, follow the patient around, is we've done a couple of trials with some skilled nursing facilities that have access to our medical record system with very tight controls, as you might imagine. And there's all kinds of legal ramifications of doing this because we don't own them; they're not necessarily an affiliated provider or anything. But allowing someone who receives that patient in the nursing facility to be able to literally look up exactly what happened. Look at the note, look at the discharge med rec sheet, look at all of those things directly to try to catch the problems. We've also kind of figured out, we've got arrangements with like 7 or 8 nursing facilities now. We've agreed to a standard set of forms. So when they transfer patients to us, it's always in the same form and format. When we transfer patients out to any of them, it's the same form and format. So everybody gets their muscle memory of exactly where to look, what to expect, how to catch things, where's the allergies noted on the form, and things like that.
That's important.
That can try to hopefully standardize it.
I'll just add that we do get their feedback on HCAP scores,
Okay.
about how we're doing with the medication education.
You want to briefly explain HCAPS?
Um,
I'm not sure everybody's familiar with that acronym and the
So,
process.
I don't even remember what all it stands for. Do HCAPs?
Healthcare assessment and provider survey.
There you go.
I just know the HCAPs report comes in the email. And so, patients.
So it's a required survey that's done, and it's a measure for CMS, and it's tracked, and it's a patient satisfaction survey essentially. So it's really key in all levels of care.
Right, so it's one of the metrics that we're watching as we put more and more pharmacists up on the nursing divisions in the hospital to see if we're doing a good job educating them on their medications. Are they happy with our services? So most hospitals get that feedback. Our retail pharmacy, we have techs that come over and support the discharge prescriptions if the patient would like. They're awesome. Our techs really work their butts off running around the hospital, filling scripts, getting payment, making sure insurance goes through, and trying really hard to appease the patient, whatever the need is. And even once, one of them paid for the prescriptions just so that they would get them to get out of the hospital. When I was up there, I was like amazed that, you know, a technician at that level was nice enough to do that. So we also have patients that can come to our patient safety committee so they can give us feedback or help us out if we, you know, need that. So just those are just a few ways that we involve patients.
That's good. You know, another really important area, and I think intertwines with all these medication safety things, is quality improvement. And usually there's within health systems a whole cadre of individuals who are solely responsible for quality improvement. With regard to these transitions of care, so are there any quality improvement initiatives going on in your institutions?
Yeah, there's tons. So quality improvement, I guess, around transitions and pharmaceutical delivery and accuracy and those kind of things, I think are centered mostly on, some things actually we just talked about, which is how do you have the record be correct? How do you get the right measure in the hands of the patients going home? We're experimenting a couple of different ways. Barnes is actually doing a program where the first 30 days of medication is given to the patient at discharge. So, so they literally walk out of the hospital with all of their bags with stuff. Everything's labeled. Everything's set up. They can do it in different languages if that's needed. All those kind of things. Some benefits of that there's not a filling issue. The problem with that is they haven't gone back to their community pharmacy and reestablish what the new record is, what they should be taking going forward. We've missed that link, and so they're trying that out. They're already seeing that there is a limitation with doing that. At Christian Hospital, there's a transitional wellness program where we have nurse practitioners trying to again see people within the first several days out of the hospital, feeding things back. Again, interrogating the medicine list that was actually picked up and is being taken, instructions, kind of reinforcing feedback and that kind of thing. So there's little pilot projects going on. You and I have talked about a project in Missouri Baptist to try to increase involvement of pharmacists at the discharge process and see how that's going to help out. So there's different kinds of ideas out there.
I think I'm going to take a break here and ask if there's any questions from the floor. You can raise your card up and we can come around and get it or pass it down. Okay, let me see if we can address these. What is the patient to pharmacist ratio? Patient to pharmacist ratio. In other words, it sounds like you're doing MedRec on everybody and it's a pharmacist, right? And so how many are we talking about admissions per day, or is it 5 or 50? Have any idea?
How many actual admissions are going through our institutions?
Well, I'm looking for, particularly with the services related to transitions of care, you know, if maybe it's a discharge education, maybe it's a medication reconciliation, how many patients or discharges is a pharmacist responsible for in a day
In the hospital setting.
in the hospital?
So I have some numbers. It really depends. We have pharmacists, like I said, on many different divisions up on the floors. And every division has a different patient load. Some of them are very quick turnovers. So our telemetry unit, there's days where they will do 18 discharges, which is hopping. On weekends, we just have one pharmacist, so we try to prioritize high-risk patients. And we have huddles with our care managers and the pharmacist on the nursing divisions every day to find out the discharges. And then on Friday, they do an afternoon also for add-ons that may be discharged. Those high-risk pharmacists for us in pharmacy would include care managers high risk, which would be the 30-day readmission patients that we want to capture. And then also patients that may be discharged on high-risk meds that are new for them. So those are ones that we try to get those weekend pharmacists to go and complete if they haven't been completed on Friday at some point in time. So 18 is a heavy day for a pharmacist up on the floor. A lot of times, some of them only do 4. So there are other things that they do, you know, that they find to do many things. The nurses pull them, they educate, they do little in-services for nurses. They're always reviewing charts, they're changing, you know, looking at labs, changing doses, IV to PO, all the little things that we've been doing for years. So anywhere between 4 and 18 a day. Our average is that, you know, that we capture in a day. I can't really say that there's a true average because sometimes our census is high. And on those days, we may do, you know, like 60 or 70 patients that we capture across the hospital that are being discharged. We try to get all of the patients, but it's hard, especially on ones that have surgery and they're just there for overnight and leave early in the morning before the pharmacist even gets to the floor. But a lot of them have worked out systems where they will educate the patient the night before. So they're doing a really good job. We still miss patients. We probably miss on the divisions we're on. We probably miss about 3% of the patients. So we're getting the majority, and we figure that's better than what we were doing before.
That's good. So Anastasia, follow-up question regarding the CHF clinic and how that, maybe some details about how that works. For example, you know, what are the activities and how long is spent on counseling and that kind of thing?
So right now, the way the clinic works, not to get into the politics of BJC, so that is a BJC medical group clinic. So we're trying to pull from patients that their primary care or their cardiologist is within BJC medical group. So by all means, I don't want to make it sound like every heart failure patient we discharge follows up with this clinic, because right now that's not the system that's in place. So what happens now, a physician, either a hospitalist, myself and my peer, Katie, have put in consults, even cardiologists. So somebody consults the CHF clinic, and then a nurse practitioner comes over and does patient education, and they really go in depth. Right now they are doing the medication education. We have worked with them a lot on developing their materials from a health literacy perspective as pharmacists, making sure the things we think important are in their education pieces, but right now that's really part of their workflow. So after there's some education, especially with a new diagnosis of heart failure, they try to see that patient within 5 to 7 business days from discharge, so very close follow-up. And I think so far they got really busy really fast, which wasn't a surprise to many of us. They have a fairly large patient base quickly, but that's kind of the process right now. And they're hoping to expand that to kind of some more outpatient education. I think they're going to call it Heart Failure University. So trying to get those patients in for more comprehensive education on a regular basis. Because again, I think we all know that education at discharge is great and it makes us feel good, like we're doing good things. But again, it's really hard for the patients to absorb all of that crucial information after they've been in the hospital for a few days and just want to go home. And so they're really trying to extend that past that moment of discharge.
It's hard for them to absorb, especially when they're a dentist. Levity. Sorry.
I got it.
Yeah. So for Dr. Pogue, back to the folders, that's a great idea. Mike, maybe a little more detail there. Is there information, you know, that what goes in their folder from a legal perspective, and is there handwritten information that's in those folders?
Yeah, there really can be any kind of information. So often, again, key test results that maybe a pathology report if they're coming out that a doc will want the patient to have coming home or coming out of the hospital. I've literally handwritten stuff and put it right in the folder and say, here's what I want you to do when you go home. Often the specialists will have their cards and put their cards in there so they don't recall or try to go to follow-up appointments. It really can be anything. As long as it fits in the folder, it can go in there.
There's no restrictions from policy or, you know?
No one slapped my hand yet.
Yeah.
We're just going.
That's good. One last question, and it comes from the American Society of Health System Pharmacists, the December of 2008 white paper. There was a statistic included in there. 48% of injection errors come directly from the hospital pharmacy, and the result is 1.88 patients are harmed or killed per week per hospital. And I'm not familiar with that data, but so the question is, do those kinds of medication errors affect the readmission rate? Is that one of the contributors? Is medical errors, medication errors that contributes?
They do, although if they die from the injection, they're not going to be readmitted. But
Yes.
so
That's a good way to decrease your readmission.
Right. Tom's shaking his head. I don't know.
Yeah.
So yeah, the medication errors are a big deal. Medicare actually keeps track of these kinds of things, and 2013, interestingly, was the safest year in the history of Medicare for these types of errors. So particularly in the last couple of years, as people have kind of focused more attention on the issue, as patient safety and other kinds of things have risen up in healthcare systems and devoting more time to it, we're at an all-time low for medication errors, and that's been kind of an awesome thing just dealing with.
I'm going to stay on that theme for medication errors real briefly, but what is the error culture like at your institution? In other words, are there active things that are done for patient safety culture? You know, a just culture has been talked a lot about. If you make an error, are you persecuted or at risk of prosecution? Or is it a balance between, you know, your job responsibility and just the process of providing care?
I definitely think at Missouri Baptist, Tom and the other leadership have worked very hard to make it the just culture. So I think, you know, the only way we can get better at medication errors is to make sure they're reported. And I know that sometimes that is difficult for other pharmacists or maybe nurses or physicians to think in that way, that reporting it is really perpetuating it and that you're opening the door for that error to continue to occur. And so we have a system you can even report anonymously if you want, and then those are filtered through committees and go to appropriate management for really just conversations. I mean, I'm not aware of a lot of punitive action that's taken, but more just making everyone aware of each other's errors without persecuting that person, but maybe so we can all learn and just prevent that from happening again.
What about in the outpatient setting?
Yeah, so one thing we do and started doing in our current team at Lindell in particular, but reporting is encouraged. It's not, I kind of agree with that in the sense that it's not necessarily punitive. What we try to look at is more root cause analysis, so trying to come back together as a team and figure out why something happened, not exactly necessarily the who, but really trying to place an emphasis on the process. And you know, there's in the community setting anymore, there's a variety of checks and balances that occur all throughout the medication dispensing process that can enable you to really try to pinpoint where something could be going wrong and enable the whole team to learn from it.
So last month at St. Luke's, we had all mild to moderate errors, and we had 13. That's all. Of course, what I'm really saying is.
13 reported.
Very
So-
underreported, yes, because when you consider timing and everything else that can be considered or identified as an error, there can be many. But we try to take the opportunity of those very few that are reported and dig into them, root cause analysis, and see if there's any improvements that we can make. So in our hospital, we have a team that meets just for medication errors, our med safety meeting. And we discuss those. It's very interdisciplinary. We work through what sort of processes can we improve, how can we work together to make sure this doesn't happen again. We like near misses because they also give us the opportunity to make improvements. Errors can be painful, and so we try to learn from other people's errors, so we share the errors in our meetings independently, so the nurses in the nursing division share what happened, and in pharmacy, we always share, and we blank out any identifying information of who the patient or the person was involved in the error, and we discuss those errors in our meeting. And I think everybody realizes that could have happened to me. Everything's really complex, and so it's easier to learn from somebody else's errors. So we also discuss on higher levels in other meetings some of our errors.
You know, just a sideline, I don't know if you read the paper yesterday, but there was a nurse in the Parkway School District who administered a flu vaccine that wasn't an influenza vaccine, it was insulin. And the teachers that received that were seriously harmed. And so there is a syndrome called the second victim. And the second victim is usually the person who causes the error. And that person has quit her job and she's gone into hiding. Obviously, there's litigation pending, and you know, I'm sure she feels terrible. But there were some dates as to when she got her nursing degree, and it looked like she's at the sunset of her career as it is. But nonetheless, I think it's a very important issue. So change gears a little bit, and we'll talk about accountability. And you know, with all this emphasis on readmission rates, how does that filter down to the clinician in the trenches? In other words, are the dashboards that track these rates, and do you see them? Do you have meetings where you discuss the readmission rates, maybe by disease state? How are operationally what's happening in your institutions with regard to information about the rates?
I think most healthcare institutions, at least the larger ones, the hospitals and similar facilities now, have groups that have worked on this and have the data, particularly from government agencies, about who's been readmitted, who hasn't, what are the rates, what are the different levels. You can break it down fairly easily. And so I think most healthcare systems are doing that now, where you can kind of go back and you know, learn from all the folks that bounce back and try to figure out what do we do, what didn't we do, and how do we you know, close those loops a little bit. So yeah, there's a lot of interest in it. In terms of the clinician in the trenches, the clinician is increasingly being held responsible to try to prevent that from happening, but they can't control it. And so I think most systems are starting to figure out, in addition to all the processes we talked about tonight, is how do we have each person who's in a different spot and owns a part of the care of that patient, how do they all tend to work together? How do we connect them? And that's been the new challenge of how can I take information that's in the hospital and have that flow out with the patient in an accurate way, so that a home health aide or the pharmacist who fills the prescriptions and the social worker who calls them, all are kind of working from the same set. For instance, a couple years ago, most healthcare systems took out doctors' handwriting. They digitized their prescriptions. They did other things so that you're not looking at the scribbles anymore. So something as simple as that can be a real gift to humanity, particularly your eyes. So to try to decrease the error rates, and how can everybody in the system know the patient? To understand enough information about them to say, okay, well, if this is your issue, then these make sense, or that really doesn't make sense. And I'm going to call your doctor because that doesn't look right to me. There's no real reason you should know that if this was really your problem. So it's finding ways of having that travel with the patient in a transparent way that I think is focused
I'm going to ask for some specific examples, and obviously we're not going to use patient identifiers or anything like that. We want to make sure we're HIPAA compliant here, but can you think of examples within the last month or two that you've interacted with and known at your own setting where either positive or negative examples of transitions of care? What things have worked and gone well, and you've saved lives and done great things, or things where you've seen harm come from a problem with transition?
So this one was not in the past month, but it was very traumatic for Katie. I can't remember who was even taking care of the patient, Katie or I. We're kind of just the same. So we had a patient who was discharged post-MI on ticagrelor or Brilinta, one of the newer antiplatelet agents. And we have a lot of rural referral patients at Missouri Baptist. So he went back to his little Southern Missouri hometown pharmacy with this antiplatelet prescription, and they didn't have it in stock when it was Friday afternoon or Saturday morning, so he didn't fill it. So he was back at Missouri Baptist with another MI. So because that stent closed up without the antiplatelet therapy. And so obviously that's a huge issue and related to, we always try to educate the patients, like you have to take this medicine no matter what. Like if you can't get it, you need to call, and we have samples and things like that. So I think it was just that weekend issue. It's Friday afternoon. The patient got discharged, no one probably talked to him, and he probably had the worst possible outcome from missing a medication that he can have.
Anyone else with anecdotal experiences?
Yeah, mine was a little bit more positive experience.
I can give you a good one. That was really dramatic.
Get your attention, right? No, I had a patient come by that, one of those big long lists. I'm not in the dispensing pharmacy. I'm really close to it. I'm lucky and blessed enough to have an office space where we can sit down with patients and talk a little bit more one-on-one in my office. But every once in a while, a patient gets, that big long list of meds, discharged from the hospital, that, say, hey, Clark, you want to maybe sit down and talk with this patient a little bit longer than we can. And I got to sit down with this patient. Actually, the changes weren't as dramatic as you think. It wasn't a totally new PPI or some of the others. It was actually simply just the hospital formulary changed the dose a little bit. Certain medications, it was the same thing taken twice a day, but the patient had basically decided, it had been a day plus or so since the patient had been discharged from the hospital, and just decided not to fill it. Was just confused by the idea, wasn't comfortable with it. So something that even us as healthcare practitioners might look at and say, well, that's the same medication, just, a different dose, and you take it multiple times per day. The patient simply wasn't willing to take anything, much less what they were discharged. And so they're kind of sitting down, going through the patient, and then getting a different strength that the patient was more comfortable with, something that seemed relatively simple, allowed the patient to take the meds, and we followed up, and she seemed to be doing pretty well. So sometimes even little things that we wouldn't think could make a difference, I think, could be the difference between a 30-day readmission and not.
Yeah.
I do think sometimes it's hard from the hospital pharmacist perspective. Like that's a really nice, fuzzy story. But so from my perspective, you feel like you talk to the patients and like, I hope that the good things happen. But I think it's hard, and especially what Kathy's been talking about. Like it sounds like they're doing great things. How often do they get the positive feedback? I feel like if I see them again, it's because they came back to the hospital.
Yeah.
And so I think sometimes that's hard from the inpatient pharmacist perspective. You hope you're fighting the fight and everything, but it's hard to get that feedback.
Very good.
I'll give something more general. A lot of electronic medical record systems for physicians these days, the prescribing modules in those have kind of automatic interaction checkers and things like that. Patient safety in general is well served by those, right? So a lot of things are caught. There's a lot of red flags that come up in front of your face that don't let you prescribe something without carefully going through an interaction. Those are good. What happens to us is that our outpatient electronic medical record does that for us. Do that for a number of years, and pretty soon your brain kind of goes a little soft because you're reliant on the computer, right? Nothing necessarily wrong with that as long as the computer is okay. Unless you go into your hospital to follow your patients, and now the hospital ordering system and prescribing system doesn't do that. And so we've certainly been saved multiple times, let's just put it that way, by our pharmacy department, because a lot of our docs, when they go in to see folks in the hospital, will rattle through things. And if there's, especially one of the newer medications or something where you're not really, it hasn't really been ingrained in your head yet where all the interactions are, these things will pop up. We don't catch them because there's no red flag on on our computer systems in the hospital. The other pharmacy department catches those, and so we owe certainly a lot to the.
In our system, when we built it, there was a lot of discussion about those pop-ups. And we tried turning them on at a lower level for the physicians. And several of them that had louder voices didn't like that. So their level is very high at contraindication for any adverse reaction or interaction. So pharmacy does get a lot of those interactions. And I just wanted to add, just so that everybody is aware, and it's one thing that I'm kind of passionate about, is getting the patient allergies in the system correctly. And I'm sure every pharmacist gets that alert continually in your system. And we try to really emphasize with our nurses when you're taking the patient history to put down what the reaction was, because so often it's not really an allergy. And we can identify that if we can see those reactions.
That's good, thank you. You know, that's a good segue, talking about this HIT-related things, and it's time for another audience poll. Raise your hand if you've heard of Missouri Health Connection. Raise your hand if you've heard of Missouri Health Connection. Good. That's probably a few more than I was thinking of. Missouri Health Connection is the HIE, the Health Information Exchange. And it's now fully up and running. Not fully, but I mean, it's functional. And it's made great strides just even in the last year and a half, 2 years. And so, they've had some early adopters. The large health systems like BJC and Mercy and a number of other folks even in the state of Missouri have joined and signed up. And then what they're doing is they're asking their patients, because it's an opt-in system, you as a patient in one of those panels, you have to sign a form. And I signed one of these forms about 6 months ago when I was in the laboratory. I was giving blood, and they said, we're having this consent form, and they started telling me about Missouri Health Connection, and we've been doing some research planning with that group, and so I'm aware of that group. And so I signed it, and it looks like right now there are about 8 million Missourians who have opted in, so it's a very large system. And there's two components really. There's kind of a viewer form where the clinician can view the health records. Let's say you're at Missouri Baptist, but they were admitted to St. Anthony's or Mercy or some other hospital outside your system. Those records will be searchable with a viewer module. And you can look up what their discharge summary is or what their CAT scan report was at a different hospital. And so the other is secure messaging. So physicians can message one another with protected health information in a secure manner so that it's HIPAA compliant. And so that you can have email now about patients with really critical information with. So, panel question then is going to be, in the context of this evolving Missouri Health Connection and a health information exchange, what are the opportunities with that with regard to transitions of care? How can that help, and what are some potential unintended consequences that might develop?
One thing I think, particularly from the community pharmacy perspective, is the opportunity to start to participate in electronic health records. I think far too often, for as many community pharmacists and pharmacies as we have, 60,000 points of care across the entire United States, to have pharmacies involved within electronic health records. And this is a good example where hopefully pharmacies are included. One of the things that we do on the EHIT Collaborative is try to work on a national level and get pharmacists at the table. So when they're making these meaningful use rules and a variety of high-level EHIT decisions is, okay, how could a pharmacist interact with this healthcare record? How could an MTM that a pharmacist does be put into the health record and then be communicated to that? So I think it's another opportunity to make sure that as a profession, and a significant percentage of the profession is in a community pharmacy to make sure that they're at the table and part of the ability to work with the healthcare team.
I mean, I think the potential advantages are pretty obvious. You know, thinking, again, being kind of spoiled in the BJC system, if that patient's been to another BJC facility, we kind of had unlimited access to those records, which is great. But obviously our patients won't just stay in one system, so they keep hopping around.
They go to the VA,
I
right?
know, the VA. The VA, you know everything
They have their own
did. Yeah,
system too, right?
they've got it going on at the VA. They can keep track of their people. But I think one thing to keep in mind while, I mean, you hear that concept and you think, well, I can know everything about the patient all the time, like how can that not be great? And I will say that, I mean, there's limitations even when we can look at all their admission records within a BJC facility. So I still think that, you know, we need to keep in mind, yes, sorting through all of the progress notes from their Mercy admission, like how will that really be able to be used, you know, while we're rounding on a patient and about to see them. So I still think that there's room to improve, and again, the patient-centered care, getting the patient involved so that we're not just reading a piece of paper to understand what went on in that last admission, because it's not going to tell the whole story.
Yeah, I agree. I would love to be able to, I mean, look, there's many hospital discharges that aren't that sick. It's routine, it's simple, you know, there does not necessarily need to be a big tome of knowledge that shows up in the community pharmacist's email that, you know, needs searching, you know, to do things right. But every once in a while, there really is. There's somebody who's frail, who's complicated, who's had a rough go, and we really need to get it right, or this is going to get really bad in a hurry. That I'd love to be able to send either an email or attach, you know, a discharge summary or what's called a CCDA, a continuity of care document that's kind of a federally approved set of information about the patient, and be able to zip that over to say, hey, Mary's coming to see you. Here's the scoop, and in particular, here's a copy of the prescriptions on an electronic basis that again are accurate. So you've got an idea of what's going on. I mean, it's not often, and you don't want to overwhelm people with stuff they have to read. And of course, when you have possession of information, there's liability that comes with that, because if you know something, now you're required to act on it. So we don't want to increase that kind of liability. We're sensitive to that. But there are ways that that increased communication in that kind of form, if it's through a secure network, that could be of benefit to everybody. You know, the pharmacist has a clue. The doctor's ideas are being communicated clearly. A problem with those ideas is effectively recognized, and that creates redundancy in the system, the safety check. And the patient gets better care. So I think there's real value in people sign up for that.
So I think that having that information electronically available in many different areas in pharmacy is very helpful. I know working in home health and in long-term care, a lot of times all you had at your hand was the paper, the forms that people printed or filled out and thought were important to send to you. So having access to all the patient's labs from their recent or long-term, I think could be very helpful in a lot of different settings for pharmacists.
Very good, thank you. I'm going to take the monitor or moderator's prerogative and ask for a final score. Does anybody know?
3-1.
3-2, cards move on. The last thing I want to do is get a few more questions from the field here, from you, the audience. So maybe raise your hand if you've got one.
Okay. I'll let you make that out. We have a statement here. Go ahead and, oh, you wrote it down. Okay, I'll let you read it. Okay. Thank you.
Not a question, but a statement, so thank you for that. So with all of the conversation and transfer of information, unless the patient is completely honest with the medical staff, the system will not completely work. And I think that's true. It's hard to do the direct when they don't tell you the nutrition or the natural supplements that
Well,
they're
it's
taking.
like he was talking, Dr. Polk was talking, when they come in with the bag,
Yeah.
A lot of times the patient, they never throw anything away, they throw everything into that.
Or they have two bags. Here's the one I'm going to show you. Here's the one I really use. I do that with Halloween. Okay, let's see. So hospitals should have a different page for updated medicines. A different page in the electronic health record. So this way, no mistake is being discharged. All doctors from the hospital should feed into one site. So maybe that's talking about this health information exchange and information going into one central repository. Let's see.
There's a back to it.
Yep, say that again. Oh, on that one? Good, thank you. So does a patient who comes out of the hospital with a new prescription, I see, this should meet with their pharmacist they went home with. The problem here is a different generic for the drug. So the retail drug can look different. So they're on a medication at home, they get discharged, they're on it's on the same medicine, but it's really a different product, you know, and it's not a great idea. So how do we address that? Do you have any suggestions?
I think the first fill should be done at the hospital. Like in the case she mentioned, how like the smaller rural area didn't have the medication.
Yeah.
You should have first fill, a 30-day fill at the hospital. That way the pharmacy has 30 days to get that medicine for the patient. In the meantime, if there's a generic difference, you should tell the patient, by the way, this is what your hospital is giving you, but it's the same exact medication.
Yeah. It gives you time to have that
Correct.
conversation.
Correct. Because there's so much, the problem with retail is that when someone comes in around 11 o'clock at night and they got discharged, number one, the hardest thing is to read the resident's DEA number, because they got that extra digit.
Doctor, hospital.
Yeah, so you're contacting the hospital, and the hospital, their
They don't
resident
know.
has already left, has already gone home. So now you got this patient that's not medicine, without medicine, for at least till the next morning,
Right.
or whatever. But if the hospital gives a 30-day fill, first time fill, then the patient doesn't have to worry about it. Think about it when they go home. They've already got the medicine that's already in.
Yeah, so an advocate for the mobile pharmacy is an example. Barnes Hospital has mobile pharmacy, and it's a very sophisticated program. And they've done statistical analyses on things like that, and it's a highly valued service. It's an optional service right now. You know, the patient gets to choose whether they use that or not. And they're not obligated to fill subsequent prescriptions in their outpatient pharmacy, but yet it does give them that additional fill. And that primary non-adherence is one of the greatest problems for medication adherence. Thank you. Here's a question. Has anyone began to use the CPT code specifically for transitions of care? If so, how have you implemented that in the payment structure? So are you all familiar with the CPT code? Those of you who are, you can comment.
It's from the government, so it's a pain in the neck.
Yeah.
So what has to happen is for a transitional care code to be done, the patient has to have their medicines reconciled within 48 hours of discharge. They have to have care management contact. They have to have their first office visit within 7 days of discharge. You then can see them as often as you want, up to 31 days, but you can't charge for anything until day 31, in which you have to drop all charges then at day 31 into the Medicare system. So there are actually some leeway as to who does all of those things. So can you have a pharmacy intervention as part of the medicine reconciliation? Absolutely. It doesn't have to be done by the doc, doesn't have to be done by physician office staff or something like that. There's ways to be collaborative on this, to say who's going to take care of each piece of that. But none of us can, there is money available for folks who will do the work. None of it can be charged until day 31. So you have to do the service, hang on to it, remember, and then drop it at day 31. So it's a little bit hard to implement in some of the current medical record systems because they just don't hold charges for days like that and then drop them later. So you have to kind of go back to scribbling on pads and remembering who and what and all that kind of thing. But there are options for collaboration for that.
find out more about that?
Question is, how do you find out more about the CPT codes for
I wanna hear
transitions?
more about
Yeah.
Yeah, so the, I tell you what, do you have something specific you want to know? And I'll try to address that.
CPT code and whatnot, how to bill, like you said, you got a process like that. How do you establish a program like that?
Yeah, well, the easiest way if you want to know the regs is, literally just Google CMS transitions of care payment. And there are sites both that are governmental and non-governmental that'll walk you through the requirements and all that kind of stuff. The actual requirements are in the Federal Register, but you can either get direct access those at cms.gov, or again, there's a lot of sites. There's medical sites, I'm sure there's pharmacy sites that will kind of explain what you have to do and how it has to be documented. It's going to be easiest if you're in some kind of collaborative business arrangement, because you're talking about essentially a bundled payment for services rendered by two different people. So if it's a pharmacist who's employed in my same hospital system, that makes the money division kind of easy. If I'm doing that with a community pharmacist, I probably need to have a business agreement with the community pharmacy and that pharmacist, so that when that money does finally come in, which one of us is going to bill which one part? How do we audit and adjudicate exactly who gets what and at what times? So there's a business process there. But in terms of what you have to do to qualify, yeah, that'd be on the CMS site.
Do people are doing that?
There's a number of pharmacy organizations who have had discussions on listservs and things, and that's another potential source for finding information. I don't know if you belong to any of those, but ASHP has been all over that, for example. Kathy, do you have any experience?
Yeah, actually, discussed it at the Hematology and College Pharmacy
Okay.
Association.
Yeah, HOPA.
Yeah, HOPA is Pharmacy Practice Manager, the whole transition of care and how to get billing and involving outpatient. And it works really well with networks that have both outpatient providers and inpatient providers. That seems to work the best for it, but involving getting arrangements with corporations such as Walgreens seems to be helping quite a bit.
And so I'll add my own personal 2 cents worth here too, is just from other experiences. These CMS determinations of eligibility are regionalized, and it is possible that while someone might be having success billing in Philadelphia, they may not get the St. Louis office to approve that. And so there are some regional differences across the country in the interpretation of the rules when it comes to billing.
On that, looking at who your MAC is, which has to, we're in this MAC District 5, so we're in the same one with Illinois, Wisconsin, and I believe Iowa. That also helps not only with J-code billing on inpatient side, but also all your CPT billing. They have a lot of your rules and regulations specific to your area.
Yeah, so incident to billing and all these other mechanisms that do exist, it's kind of by the MAC that you're in, so make sure you're getting information from people who are in the same group. Another question, how do we more directly engage the patient in sharing of their own information in the working with the care team? So online access, electronic communication, etc. Maybe if you were familiar with the blue button and the personal health records, anything in that realm.
I don't know about the blue button, so I can't speak of that, but I always thought when I go to a hospital with someone in the family who may be ill, I would love to just put the medications in myself, because I can't tell you how many times or list I've given and the meds are wrong. They're wrong the whole visit, they're wrong when they leave, they're wrong at the nursing home. It just goes on and on and on, and it's so hard to fix. So I think that there's a lot of people out there that are probably very proficient in computers and could probably enter their own language on the computer and would certainly do a very conscientious job of getting it right. So.
The blue button is a functionality on electronic health records. I think it was either in the VA system or the Department of Defense. Anyway, it was a government, I'm pretty sure it was the VA. There was a blue button, and then the patients would go to that, and it was a generally recognized icon for patient portal entry for their own personalized health information. They could add to it and find information, so that's and now it's been widely accepted by other, Kaiser Permanente has the Blue incorporated or implemented the Blue button in theirs as well.
Yeah, the electronic health records are getting better about that, about having those kind of patient portals and kind of the download of the key information into those. I mean, the biggest, I think, catch is what we were talking about earlier, which is, okay, I can download from my system into the patient's smartphone, these are those patients who have such things, and they can have that there on their phone, but how do I then allow that to be accessed, say, by a Walgreens pharmacy or a community pharmacy, and have them easily be able to see that and have the patient say, well, here's what I'm supposed to be doing, and have that translate. So I think that's been part of the issue is how do we get these things to talk to each other, because Epic and Cerner and NextGen and other kinds of McKesson and other kinds of systems have it, but they don't necessarily. It's not like a recognized standard.
I still think that, so while the information is there and it's great that I know we have My BJC, I think is what it's called, within the BJC system, but you still have to get the patient to want to participate in that conversation. And so I'm not sure what we're doing at Missouri Baptist as far as encouraging patients to sign up for the Health Connection. I mean, I think that that's a great program, but the patients still have to want to participate and recognize the importance of their healthcare providers communicating and then playing a role in that conversation. And so, I think obviously our older patients struggle with any kind of technology sometimes. I mean, I'm not making a blanket statement, but I do think, we think, oh, well, it's online, you can look at this. Sometimes you have to take a step back. There's still not a laptop or a computer in every home. There's still not wireless internet in every home. And so, decreased accessibility and then just the patient understanding how vital that can be in their healthcare.
Yeah, the last thing I'll follow up with, I think it's pretty obvious as we look at technology that it's growing faster than we as even health community people are using. The ability for technology to make a difference is growing faster than we adopt it and use it on one hand. And then on the flip side though, when it talk about engaging patients individually, I don't think we can lose sight of the effectiveness of effective relationships with your doctor, with your pharmacist, with your nurse, with your healthcare team, whether it be motivational interviewing, health literacy, things that really communicate on a patient level. We've noticed we can grow technology this fast, but ultimately some of the things that still slow it down is, I mentioned, does the patient want to tell you the truth? Does the patient want to communicate effectively? And part of that is on us as providers.
And I'm going to wind down. I think our time is up, and I want to let you know that there is a kind of a chartreuse piece of paper that you have that's an evaluation form for this program. Go ahead and start filling that out. Stephanie will be coming around to pick that up. I do want to ask one last question. So while you're kind of in one ear on this last question and then also on filling out your form. If hypothetically the medication list on discharge is 100% correct, what is your opinion on requiring within 24 hours of discharge of medication administration prior to discharge? Maybe, so an example is a heart failure pharmacist sees a patient, they're on the Lasix, on the inpatient, but it's been discontinued and switched over to oral Lasix, without a dose response check. Is there any opinions about that?
So could you repeat that?
Well, yeah, and if you wrote this, if you want to clarify too, I may have botched it, but, so I think the gist is, if the medication list is correct, but there's a medication that needs to be transitioned, maybe from an IV form to an oral form, and it needs to be done within 24 hours before they can't get discharged. They shouldn't be expected to just transition to that on the outpatient setting. They should have some time prior to discharge to experience that medication, maybe work on the dose and something like
I
that.
think I understand now. And I think this happens more, so heart failure is a good example, but I think it happens a lot with IV antibiotics. And so related to, appropriate admission, I know physicians get a lot of pressure, should this patient be admitted? And so IV medications are usually a requirement for the patient still being in the hospital. So I think it frequently happens that we change the medications upon discharge and that the patient's getting one formulation today, we're gonna send them home on something they've never actually taken, but it's, on their medication list, and there are certainly, risks with that. I don't know how it would change, just from the perspective, like I said, of hospital admission and meeting criteria that the patient's appropriately admitted to the hospital. I don't know if Dr. Vogt has any opinion on that.
Yeah, I'd love to see someone who's enterprising, who wants to try to measure that and measure the value of that, the incidence of readmissions, for instance, and other kinds of things. Because, right, on the hospital side, they're all under pressure to have a patient transition out when you go from oral to IV, or I'm sorry, IV to oral. Medicare considers that they do not, if they're on an oral medication, they do not need to be in the hospital or IV in the hospital. And so the hospital will see dollar signs on the expense side of the ledger and wanting to have that person go home. And so, there's a lot of wisdom in what was talked about in terms of wise transitioning of medications, understanding the response. Theoretically, you should have a better outcome if we understand that there's a stable response that's predictable going home out of the hospital. So, but what's the value of that? How often does that become a real problem? How often people get admitted because they really don't respond to those antibiotics we transition them to? The hospitals will need numbers. That sounds like a research project for some enterprising person who can go measure that.
Yeah. Well, again, I want to reiterate my sincere thanks for coming out tonight on this great night. I hope you enjoyed the food. I hope you enjoyed the panel. Let's give them a round of applause.